So my pleasure to introduce Lorenzo Del Sorbo, is working here with us in Toronto. You can see that Lorenzo is somebody very important because he has to present PEEP, lung recruitment, and cone positioning. So
in 50 minutes.
Yeah, thank you so much.
Okay, thank you for the invitation to speak. I don't have any disclosure with any conflict of interest. I have to disclose that most of the things you will hear from me are from this article that we wrote in the annals of ATS with Eddie and all the organizer of this course, where we try to give a rationale for the recommendation of the clinical practice guideline that were published on the Blue Journal just before. And so first question, so what is PEEP? It's a marshmallow candy sold in the United States and Canada that are shaped into chicks, bunnies, and other animals, a cartoon character, or a positive and expiratory pressure. Okay, 20 seconds. They're not mutually exclusive. You can check all that applies. Okay, nothing, no. Yeah, so perfect, 100%. Okay, I think we can skip. So they are all correct, okay? There are marshmallows is a cartoon character and positive and expiratory pressure. So today we're gonna focus on the marshmallow, no, on the positive and expiratory pressure. So what is PEEP? PEEP is the parameter that we can set on a ventilator to set the baseline pressure in our circuit. So I put this slide on because it defines external PEEP, okay, as the PEEP that we set on the ventilator, but the patient may have some intrinsic PEEP, may have some positive pressure at the end of expiration, especially in patients with bronchoobstructive lung disease or COPD exacerbation, that when we ventilate patient, we should take in consideration. And so I'm not going to focus on this in this talk, but I think you'll have opportunities maybe during discussion of clinical cases in COPD exacerbation in the next few days to learn more about this. And so the total PEEP is the total PEEP that takes in consideration both the extrinsic PEEP, or the external PEEP that we apply, and the intrinsic PEEP that the patient may have. So in ARDS, we apply PEEP to prevent the recruitment. Okay, when the lung looks like this, a very low lung volume full of inhomogeneities, and if you do a CT, may look like this, completely derecruited, you want to apply PEEP to try to optimize recruitment. Okay, that has some beneficial effect in terms of gas exchange, reducing ventilator-induced lung danger. I think we had a talk about that today by Art Laske, if he came. And but at the same time, we know that applying PEEP may cause some side effect. You know, if the PEEP is excessive, that can lead to overdistension, global overdistension, which is another mechanism of ventilator-induced lung injury. And also, it's important to recognize the lung-heart interaction. So if we increase the PEEP excessively, the lung volume, the total lung volume may be so high that we actually increase the vascular resistance, or if the lung volume is too low because PEEP is not effective, also the vascular resistance can increase in this very known U shape of interaction between pulmonary perfusion and lung volume. And so that can lead to some heart failure or cold pulmonary during ventilation. PEEP has been, for ARDS, has been brought up early on, already in 1967 during the presentation of the first 12 patients described as having ARDS by David Archibald. And it's interesting that in the article they write about therapeutic trials that didn't have any effect, and in the umbrella of therapeutic trials of apparent value, they wrote that continuous positive pressure respiration was used in management of 5 patients. So remember the case report was about 12 patients, and expiratory pressure were maintained 5-10 centimeters of water. All 5 patients demonstrated rise in PO2 or oxygen saturation with the use of PEEP. PCO2 rose slightly in response to the drop in mini ventilation. Arterial blood pressure and central venous pressure improved or remained stable. Means maybe they got some recruitment if we believe that the oxygenation response here was secondary to recruitment induced by PEEP. So since then, there have been a lot of trial trying to show if higher PEEP in ARDS was better than a lower PEEP strategy. And in the meta-analysis that we publish with the guidelines, clearly we couldn't find, just like many other trials. So the summary of all these trials show really no significant difference in all-comer patients with ARDS between high versus low PEEP. And with maybe some suggestion that in patients with the severe ARDS with the lower PF ratio, higher PEEP actually may be beneficial. So this has been discussed and of course criticized a lot in the literature. And some nice data come from Salvatore Grasso that works in Italy, in Bari, who took patients with ARDS and did the PV curve and showed that some patients were clearly recruitable going from their baseline PEEP to a lower PEEP strategy and switching them to a higher PEEP strategy. So the recruited volume was very, very variable, but quite significant. Whereas in another group of patients, there was no recruitability. So whatever PEEP you would apply to this patient, the recruited volume was not significant. And that means, that suggests that maybe the response to PEEP is what matters. And those trials comparing higher versus lower PEEP didn't really investigate the response to PEEP because that was not part of the trial design. So this is very important because maybe physiological response to PEEP may be the major determinant of its impact on outcome. I think I copied this sentence from one of Ewan's paper that I'll show you later. So lung recruitment, okay, so the response in terms of lung recruitment to PEEP may be the physiological effect that we should monitor to understand if higher PEEP is better than lower PEEP for a particular patient. So this has been studied by Luciano Gattinoni already a number of years ago, and this nice physiologic study published on the New England Journal of Medicine. So it took a large case series of patients with ARDS and did a CT with PEEP of 5 centimeters of water, okay, and the same patient increased the PEEP to 45 and did another CT. And the measure was able to understand, differentiate patient with large percentage of potentially recruitable lung, as you can see here, or percentage, so lower. So here you see the end experience, or a PEEP of 5 and a PEEP of 45, the aeration, the area of aerated lung is not very different, and as well as the consolidated part of the lung here in the dependent zones, whereas there were patients that were having a higher percentage of potentially recruitable lung, just like in this representative case. And what it showed really is that the distribution of potential lung recruitment is very variable, okay, across different patients. So each patient has really very variable amount of lung can be recruited, so a very variable response to PEEP. And interestingly, the patient with higher percentage of potential recruitable lung had worse gas exchange. You see the PF ratio is expected, higher maybe shunt, and worse CO2, compliance was worse, and mortality, what is also very important for our patient, was worse than in other patient. And that was further explored. This concept of response to PEEP was further explored by Ewan in this, Ewan Goliger in this very nice retrospective analysis of randomized trial of, I think, the Express and the Love studies. And then it showed that if we look at patient where there was a change in PEEP at the moment of randomization, and the response in terms of PF ratio to this change in PEEP. So look at the red line here. There is a huge impact on survival and mortality, okay, according to the response. So a patient had a change in PEEP with a nice response in terms of oxygenation had lower probability of death than patient that didn't have that response, okay? So really, response to PEEP may impact the outcome of our patient, and this never been studied or part of a design in a randomized trial. So another way to optimize lung recruitment potentially is putting patient in a prone position. Okay, so question here is prone position standard of care in patient with severe ARDS, yes or no? These are mutually exclusive. Now 1 second. This is, I'm completely, no.
No, that was good, but you have to be on the right.
Così, here?
Yeah.
Okay, Zach, this one? No.
The other one.
Okay.
The other one.
No, tab, see, it doesn't. No, let's try this one. No, it doesn't come up.
Did you need to go back?
Just minimize and it goes back.
There is another page if you go. The first one. This one. Yeah.
Okay,
And
and then,
move.
there you go.
Okay. So let's see. Option 3, interesting, there's no option 3. Okay.
Option 3 is the marshmallow.
Okay. No. No. Mike. No. 1 second. Okay. Good. So we'll get to the answer in a second. So the prone position is alternation of a position in of the patient being on the back, supine, or on his belly, on his chest. And this alternation has been applied. I don't know if it projects well here. Also in the past. Okay, so this is a nice way of alternating position. Okay, it's a way of, and I like this very much, and I used to show this to all the residents before the Guerin paper showing benefit.
But this is Lorenzo, right?
Yeah. So I like this because you see the iron grate here is the way St. Lawrence was killed and became a martyr. So in honor of my name, I always like to show this, okay? But we don't use prone position for these purposes, okay? So the first report, if you like, history of medicine of prone position for patient with acute respiratory failure is 1976. Okay? Use of extreme position changes in acute respiratory failure. So the report is 5 patients with the low PO2, 82 on average, requiring FiO2 greater than 60% and some PEEP. And after proning, the PO2 increased by almost 50 millimeters of mercury. So quite interesting. And then it was studied a lot, and many clinical trials have been designed and conducted to show a clinical benefit, so improvement in decreasing in mortality, and a lot of publications explaining the physiological mechanism of prone position, but the result till very recently were always very upsetting, to the point that after the, I think, second last randomized trial, Arslaski wrote this nice editorial saying, improving outcome in critically ill patient, the seduction of physiology, meaning that all the physiological potential benefit from proning were not leading to improvement in clinical outcome. Okay. However, we know about the Guerin paper, and we'll talk about that in a moment. Now it's recognized as a treatment that reduces mortality, and so in the guidelines for mechanical ventilation patient with ARDS, the recommendation was given. So we recommend that adult patient with severe ARDS, so PF ratio less than 100, receive prone position for more than 12 hours per day. So strong recommendation, moderate high confidence in the effect, estimate effect. So the potential beneficial mechanism of prone position are maybe two orders, plus potentially a third one. So improving oxygenation, reducing ventilator-induced lung injury, and reducing ventilator-associated pneumonia. So we'll see. So effect on oxygenation. This is a nice report by Gattinoni in his first randomized trial in prone position, showing that every day the patient going from supine to prone position, we're having an improvement in oxygenation. Okay, and there was persistent, throughout the application of prone position. Very, very strong evidence here that there is an effect on oxygenation. And this has been replicated in most of the study investigating prone position in ARDS. So all the meta-analyses are really positive for the effect of prone position in oxygenation. However, in the subgroup or in the post hoc analysis of the Guerin paper about prone position in ARDS that show benefit in terms of reduction of mortality, the oxygenation effect. So if you divide the patient that survived versus the one that died, there's no difference in terms of oxygenation, suggesting maybe the response in oxygenation is not really the mechanism that save these patients. So let's look a little bit what's happening physiologically to these patients when we put them from supine, okay, here to prone. So in supine position, the distribution of the forces that distend the lung and the chest is really toward the sternum. Okay, so there is a lot of distension and movement of the sternum upwards, and so the lung, the chest wall, and the lung in that direction, and very little toward the diaphragm. So when the patient instead is turned prone, we overall increase the elastance of the chest wall, okay, because the patient has a hard surface on his belly and chest and sternum, and on the back there is the spine, okay, applying a lot of resistance. And so the forces of ventilation, instead of being distributed mostly, in these axes, gets distributed toward the diaphragm. And this may be, and this has a strong effect we'll see on recruitment. So this is a nice imaging of a lung, okay, of a subject in supine position. You see the forces of the abdomen here sitting on the posterior area of the lung that becomes a bit more atelectatic. When we flip this patient in prone position, these forces are away, and so there is more chances for this part of the lung, first of all, not to become atelectatic, and maybe to be re-expanded and help contribute better to gas exchange. So this has been studied a bit more physiologically in this study. So you see in a normal subject here, there is in supine position a distribution of pleural pressure that we know have been very different if you analyze the dependent part of the lung and non-dependent part of the lung. And in prone position, these variance is very much reduced. And this effect is even more impressive in patients with injured lung, okay? So there is a lot of variation here in pleural pressure, okay? It's very much, that's significantly less in prone position. And this graph shows the same thing in patient supine, in patient supine, the gradient of pleural pressure is much less than in prone position. This has a quite significant effect on distribution of ventilation, because the more homogeneous distribution of pleural pressure makes the distribution of transpulmonary pressure more homogeneous. So in this physiologic paper of published by Gattinoni in the early 2000s, you see in healthy patients, okay, in a supine position, the ventilation going from the ventral area in supine position, so ventral area to the dorsal area is quite, the range of distribution is quite broad here, and it gets much less and more homogeneous in prone position. And this effect is magnified even more in injured lungs, okay? So there is a more homogeneous distribution of ventilation. What happened to perfusion? So the perfusion study, here is the graph showing the study of perfusion in the model, in the porcine model of ARDS. So in prone position, in supine position is distributed more toward the base. It makes sense because the blood is like water and it's heavier than air, so distribute more toward the dependent zones of the lung. As we flip the patient prone, from supine to prone, the distribution of perfusion doesn't changes, but doesn't change that much. And so combining the effect of improvement in distribution of ventilation and unchanged distribution of perfusion, the VQ matching may be more favorable. And this has been studied very nicely by Richter and Giacomo Bellani was part of this nice study in physiologic study in ships with ARDS. They did a CT PET study looking at distribution of ventilation and perfusion. If you can see here in supine position, the ventilation is distributed mostly on the non-dependent area. Perfusion is, whereas the dependent area are very collapsed. Okay, when they flip the ships in prone position, the distribution of ventilation and perfusion is much more homogeneous and better, leading to the improvement in gas exchange that we mentioned before. There is an effect also on cardiovascular or on the hemodynamic condition of the patient. So in prone position, there's an increase in abdominal pressure, decrease in hypoxemia, there's lung recruitment. All these leads to some increased venous return and decrease vascular resistance, okay, because of the improvement of recruitment and gas exchange. So this leads to an increase in preload and decrease in RV afterload. So the LV overall gets a little bit better. And this is the LV preload increases. And this is good if, and if the preload is preserved, the patient may have an increase in cardiac output, so improving perfusion and oxygen delivery to the distal organs, and or no change in cardiac output, so no much side effect if the patient, the preload reserve is not adequate. Okay, that means maybe the patient needs some volume resuscitation. Okay, and this is only the description of all the variables that you may measure from a hemodynamic perspective in prone versus supine position. So there is an increase in atrial pressure, right atrial pressure, wedge pressure, and the pulmonary vascular resistance decreases. So all these, as we said, affect oxygenation, but there's not maybe the mechanism of the effectiveness of prone position in reducing mortality. So the effect maybe is on reducing ventilator-induced lung injury. So there is a nice study showing that prone position really has a strong effect on reducing ventilator-induced lung injury. In this model in normal dogs treated with very high transpulmonary pressure, with extremely high tidal volume, leading to extremely high tidal volume, 77 cc per kilo. In prone position, you can maybe appreciate the lungs look much better than in supine position after 6 hours of ventilation. There is less, there's more recruitment, less stress and strain. So that's indicated by the transpulmonary pressure here in prone versus supine position. And there is also less inflammation. So there is less cytokines in prone position, both in BL in blood and in the BL. This is interesting. The activated neutrophils marginating into the alveolar space are significantly less. So there is a strong effect on ventilator-induced lung injury. So all this information led to the design of this nice trial published already 5 years ago by the French group. So ARDS is defined by the American and European Consensus Conference criteria, and they recruit the patient mechanical ventilator intubated for less than 36 hours. So they apply prone position quite early in patient with PF ratio less than 150, requiring FiO2 greater than 60%, and the people of at least 5 centimeters of water, which is reassuring because also with the new definition, they would still meet the criteria for moderate severe ARDS and ventilated with 6 cc of tidal volume per kilogram of predicted body weight. And there were some contraindications. Some of them were absolute contraindications, like intracranial pressure or tracheal surgery or sternotomy. Others were maybe relative contraindications, and they show a great effect in reducing mortality with prone position versus supine. And so it's great. So that's why it's strongly recommended by the guidelines. It comes with some side effects, and here are some meta-analysis showing and the kind of side effect that you could encounter if you put the patient prone. Airway obstruction is one of the major one, and so I would leave with that message. So again, in the systematic review that Lavina Manche wrote and performed to support the guidelines of ARD, mechanical ventilation in ARDS, showed for all, if you look at all the study, an effect that is not quite completely statistically significant, okay, but if you consider only studies that apply prone positioning for at least 12 hours, this signal becomes very significant. And if the severity of hypoxemia of patient entry as entry criteria, so including only patient with PF ratio less than 150, also this is significant. That's why the recommendation is for prolonged period of time greater than 12 hours a day or 16 hours a day, and with patient with PF ratio less than 100, maybe 150. There's maybe a signal, that's why I put the question mark about the potential protective effect on ventilator-associated pneumonia, because there is not a significant, statistically significant, maybe a significant trend in lower incidence of VAP in patient in prone position compared to the one treated in supine position. So I hope that all your institutions have a policy, to help the personnel to put patient that meets those criteria in prone position. Here we, in TGH, we have one. I know Manzani has one, but I know there is a lot of reluctance in certain centers to put the patient prone. So there's always a quote, or Mansebo said, we need 10 people to put someone prone, 3 to do it and 7 to complain about it, but it's very effective. So with that, I conclude, and happy to answer any question. Thank you. Okay, one question about marshmallow.
So Lorenzo, do you always paralyze your patient?
Yes, we always.
This is part of your
paralyze.
policy?
So we recommend deep sedation and because usually patients have PF ratio less than 150, so we have very low threshold to paralyze them, and we not necessarily keep them always paralyzed when they're prone, but I think at least the first proning session is done with the paralyzed patient. I don't know if there's a lot of evidence about that, but that's common practice.
But you're saying it's about the same threshold for paralysis and for prone? So
Yes, and so they often come together. Okay, thank you very much. Enjoy the rest of the course.